I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
Hi, I'm Dr. Randy Martin, and I'm thrilled to be joined by Dr. Mack. Mike, well known to all the audience. Mike, you just gave a fabulous talk on the future of mitral valve therapies. Really, you were looking to 2030. So give me a retake of that. What are your thoughts of where we're going?
So, as I ended it with the Yogi Berra quote, this is deja vu all over again.
Right.
We've seen this scenario play out with TAVR. And so it's the same pathway. The timeline's not the same.
Right.
The timeline is going to be longer. Indeed, the first MitraClip was done in 2007. We're 12 years down the line. Actually, it was approved in 2007.
Right.
And, we're 12 years down the line, and the adoption rate's not nearly as high as TAVR, but the paradigm shift is going to be exactly the same.
You're saying transcatheters.
Transcatheter, yeah. And, the first rule of a treatment of a patient is less invasive always beats more invasive as long as the outcomes are roughly equivalent. And it's even if the short-term outcomes are roughly equivalent, hence stents versus Lima to LAD.
Correct. Mike, so if you look toward the future, you've got a plethora of devices that could be done transcatheter with a transcatheter technique. You went through all those. Where are we going with all of those? In other words, we've got multiple iterations of annuloplasty, chordals, clips, valves. Where are we going to go with all that?
So if you really think about it, all of these devices are based on surgical principles. Mm-hmm. And most of the devices were actually invented by surgeons. So if you think about how we do mitral valve surgery, it's not like TAVR,
right.
where you got one disease,
right.
You put in one valve, and that's it.
Right.
There's multiple things that need to be done. So the surgical tools that we have available to treat all patients that are not the same will be available on a transcatheter basis. And we're getting smarter and smarter about which patients are going to be appropriate for which repair therapy and also which ones for replacement. Patients that you have severe MR but don't have annular dilatation, doesn't make any sense to do an annuloplasty.
Right.
So I think the toolbox will be as full as it is for surgery. Now, it's a different paradigm to get there. There are significant challenges associated with it, but if we look toward 2030, it will be there.
Mike, I've been a strong proponent of the surgeon really knows the anatomic space, has seen the pathology, the spectrum of pathology. Isn't it critical for the surgeons to stay intimately involved so that the right technology is applied to the right pathologic condition?
So I'm biased, but of course I would say yes. We have structural heart fellows in our institution,
right.
Both cardiology and surgery. The surgery structural heart fellows pick up the MitraClip, and the mitral technology is much quicker than the interventional cardiologist because you're there in the operating room, you've seen it, you know what you're looking at on echo images. You surmount the learning curve much quicker. And so this ability not only to be able to choose what to do for the patient, but actually performing the procedure is easier for a surgeon. Now, after a while, that learning curve goes away, and a cardiologist can't get there. But as I said, if I have one regret about TAVR, I didn't yell loud enough to the surgical community to be involved and to stay involved. And so, deja vu all over again. I'm not going to make that mistake twice, and I'm going to yell to the surgical community. This is yours to lose.
I think you're exactly right. I think back to the early days of AVR, surgical AVR, you never would have thought that number one, it would happen, and two, the extent to which it's happened. Mike, in final sort of thoughts, how do you tell the young surgeon or the young cardiologist who wants to be a structural heart specialist, how do they get trained?
I think that The interventional cardiology trainee has a significant advantage over the surgery trainee because they come out of interventional cardiology with wire skills already.
Right.
So if you have structural heart fellowships for cardiologists and surgeons, the interventional cardiologist is always already at an advantage because they have wire skills. So I think one is we have to train surgeons. So we're proposing a structural heart track by the American Board of Thoracic Surgery, so that a surgeon can train specifically in structural heart disease, so learn the catheter skills along with surgery, but then have a one-year fellowship afterwards for those that don't go this path, so you get a full year. Now, in order to be prepared for that full year, you're probably going to need 6 months in the cath lab to gain skills. And our interventional cardiologists are not obstructing or closing the door here. They're more than willing to help train us. They're totally on board.
That's great. Listen, you've made tremendous contributions in the operating room, in the interventional room, in the literature room, so I appreciate your insights to the future. Thanks very much.
Thanks for having me, Randy.
Okay, and thank you for joining us.